called the gastroesophageal junction because it's the junction between the stomach, which is also described as gastric area, and the esophagus, so it's called the gastroesophageal junction. Then we have the stomach. Stomach is really a mixer. It mixes all the food with juices, with acid, breaks it down into small particles, and the food then trickles down into the small bowel. And this is a part of the bowel where all the absorption of the nutrients that we need takes place, and the waste then goes into the colon, which is a long tubular structure where the water is absorbed from this waste, and then the hard stool comes into the rectum, which is when we sense that it's there, and then we evacuate it. And I think the important thing is that to remember is that these different parts of the gut are all in continuity with one another. So the esophagus and the stomach and the small bowel and the large bowel, they're all in continuity. So it's a long tubular structure with different functions in different parts of the gut taking place, but nevertheless they are connected to one another. So it's not uncommon that if there is a problem in one area, that can have effects on another area as well. For instance, if the bowel is very sluggish, that sends a signal to the rest of the gut to slow down, because it's a bit like a motorway effect. You know, on a motorway, if one car slows down, all the cars behind have to slow down. And because we're again looking at a long tubular structure, if one part is slow, then it has a knock-on effect on other parts of the gut as well. Now, if we look at the structure of the gut in cross-section, where we can look at all the different layers of the gut, what we have in the middle here is what we call the lumen, the inside of the gut. So say, for instance, this is the small bowel, then this is where in the middle, the lumen, as we call it, is where the food is going to be. Okay, these finger-like projections are projections of the cells or the lining of the gut, and this is really to increase the surface area for absorption. So these finger-like projections help the food to be absorbed. And in celiac disease, for instance, these finger-like projections are lost, and therefore absorption is not good. Celiac disease is an allergy to wheat and gluten, so these finger-like projections are lost, and therefore people can't absorb very well. But behind this layer of the cells that line the small bowel or the gut in general are these submucosal layers. These are just another layer of tissue in the gut, and this is in this layer there is a nervous plexus called the submucous nervous plexus, and behind that are the muscle layers. We have the inner circular muscle and the outer longitudinal muscle, and between these two is again a very rich nerve supply called the enteric, the myenteric plexus. So the important thing is to just remember is that the gut has this very extensive nervous system, two sets of nervous systems that are linked together, and these two nervous systems together are called the enteric nervous system, and the gut has just as many nerves as the spinal cord. So there are problems that can take place in these different layers. There can be a problem in the nerves in the gut, or there can be a problem in the muscles of the gut as well. So that's just really to give you an overview and idea about what the structures of the gut are like. And when we look at what is the, if we take a further section here and look at it under the microscope, just to see where the connective tissue is within the gut. What we see here is these connective tissue scaffolds that run down in this longitudinal muscle layer, which is the outermost muscle layer of the gut. There are these scaffolds of connective tissue. And just between these two muscle layers, as I said, is the nervous plexus called the myenteric plexus. And here's, for instance, a myenteric plexus ganglion over here. And you can see that there are a lot of collagen fibers, elastin fibers here around the nerves. So not only are connective tissue like collagen, etc., and elastin fibers present within the muscle layers, but also present around the nerves, and they form like a protective sheet around the nerves as well. So it's not beyond the realms of imagination that if you have a problem in these muscle layers, in these connective tissue in the muscle layers, or connective tissue in the layers which are around the nerves, then there could be dysfunction of the gut. The gut may not move very well. It may not sense very well. And in fact, that is exactly what was described in this classic original paper by Professor Graham and Dr. Hakim, where they demonstrated that not only patients with joint hypermobility syndrome, as hypomobile EDS and HSD were called before the new classification in 2017, not only they have joint pains, fatigue, and various other symptoms, but they also have much more in the way of tummy symptoms, gastrointestinal symptoms, compared to healthy controls, which are shown in these white bars, and these black bars show the percentage of people experiencing symptoms in those with joint hypermobility syndrome. And this has been borne out by many papers since then. We ourselves have done quite a lot of research and demonstrated that patients with hypermobile EDS, HSD, experience a whole range of gastrointestinal symptoms related to the entire gastrointestinal tract. Some have more upper tummy symptoms, some have more lower tummy symptoms, like bowel symptoms, etc. And some have the entire combination of upper and lower gut related symptoms. So just to explain further why people develop, with EDS develop symptoms and what type of problems there are, I like to divide these problems into three categories. First one is a mechanical problem in the gut, that the gut doesn't move very well. And there's a problem with sensitivity, that it may be more sensitive or sometimes even less sensitive. And there is a possibility that we are talking about the gut being a bit more leaky in EDS patients. And there's a question mark about that, but certainly from what we see, we tend to make this deduction that there may be increased leakiness in the gut, and I will explain all of this in the next few slides. So let's talk about the mechanical problems in the gut in the first instance. So just to give you an analogy over here, there's a basic law of physics which suggests that flow in a tube depends on how elastic the tube is. So the flow will always be faster in a tube which is more rigid and solid, and it'll be slower in a tube which is more elastic and stretchy. So take the example of this water tap in your kitchen. You open the tap and the water, hopefully, in most cases, gushes out. And the reason for that is that there is a metal pipe. There is this steel pipe which is actually bringing the water up to the tap. And therefore, water flows in this very solid pipe quite fast, and therefore you have a good flow. Compare that to one of these old-fashioned hose pipes, okay? And you can see, even though water will gush out from there as well, but it'll be a trickle. It'll be compared to the speed at which the water comes out from your tap. It'll be slower, and that's because as the water flows through the pipe will expand because it's more elastic and stretchy, and therefore the force of flow in that pipe will reduce. Okay, so we think that this may be one of the problems in the gut, that the gut may, because it contains all the connective tissue proteins, contains collagen as well, and if it is more elastic, more stretchy, therefore the gut will expand as food and fluid flows through it, and that expansion of the gut will slow it down and make things a bit sluggish. And this is what we tend to find in most of our patients with hypermobile EDS and HSD, that the gut is slow. And this could be due to a combination also of weakness in the muscles and the nerves, because as I showed you before, there is a lot of connective tissue in the muscles and around the nerves as well. Well, what does this then present as? So it presents in our patients with acid reflux, because as I said, that there is a valve at the lower end of the esophagus which closes when we finished eating, and it opens while we're eating. So when we finish eating, it should be closed and shouldn't allow stomach contents to come up into the esophagus. But in patients who have reflux and EDS, we find that the valve at the lower end of the esophagus may be a little bit weak, and the movements of the esophagus may be a little bit weak that allows the acid to then come up. And reflux is a very common symptom in our patients with EDS and hypermobile spectrum disorder. In more than 50% of the patients that we see, we find evidence of reflux. And sometimes not only is this burning discomfort in the middle of the chest, you can actually get acid and stomach contents coming all the way up into the throat, which can cause quite a lot of discomfort and burning in the throat and a feeling that food is repeating on itself, something that we call regurgitation. And in most of the patients, when we do a camera test endoscopy to look down the esophagus, we don't find inflammation in the vast majority of our EDS patients. They get a lot of reflux symptoms, and usually the esophagus is not very inflamed. Then we have difficulty with swallowing, so that a lot of our patients describe that the food is stuck either in the back of the throat, what we call the pharynx here, or as it goes down the esophagus, so they have a feeling of food stuck in the chest. And this is because the movements in the esophagus in particular are sluggish in a lot of our patients with EDS. They do not generate as strong a force of movement of the esophagus when the food is swallowed as it should do, which means that the food can sometimes stick, especially if it's something which is very hard, stodgy, dry foods. They can sometimes stick. Usually this is not very severe, and a sip of water will help to clear it, but occasionally we see more severe symptoms. The difficulty with swallowing in the throat is also because of a bit of sluggishness, and we find that very small particles of food may stick in some of the recesses that are present. There are quite a few recesses at the back of the throat and just behind where the vocal cords are. And sometimes a small speck of food may just lodge over there in one of these recesses, and it can give you a feeling of something is stuck there, and you have to try and clear your throat or drink some water to try and clear that. That usually almost always never leads to anything serious like aspiration or food going down the wrong way into the larynx or the windpipe, but it's just a bit of discomfort that is mostly experienced. And then a lot of our patients complain of symptoms throughout the gastrointestinal tract, and these conditions that we describe as functional gastrointestinal disorders, and there are quite a few of these functional gastrointestinal disorders. These are disorders where there are a lot of symptoms, but no abnormality is found on traditional studies like x-rays, endoscopies, etc. They're all normal. An example of a functional gut disorder is functional dyspepsia. So these are people who experience quite a lot of discomfort, sometimes burning discomfort in the upper part of the tummy, in the stomach area. But when we do a camera test endoscopy, we don't find any inflammation, we don't find any ulcers, but they have all the symptoms that would be typical of an ulcer. But you don't find an ulcer. Sometimes this can be quite painful. This can be associated with nausea, occasionally vomiting. The stomach can be a bit sluggish. There can be a feeling of a tight band around the stomach or pain. And quite a common symptom is bloating. The tummy just feels very bloated, distended. And if the stomach is sluggish, they may not be able to eat as much as they would like. Now, in our studies and in more recent studies that have come through, about 50% of the patients with hypermobile EDS and HSD who have tummy symptoms, about 50% of them complain of this functional dyspepsia or indigestion type of symptoms. Then there is a condition often described as gastroparesis. The stomach is very sluggish. Gastroparesis is a very severe condition. Paresis means paralyzed. And in most cases of our HSD and hypermobile EDS, the stomach is not paralyzed, but it is often slow. And as I said before, that the stomach is really like your food mixer. It actually mixes the food with acid and other juices and breaks it down into small particles. And just like contents over here, they slowly then trickle down into the small bowel. The first part of the small bowel is called the duodenum. But in some cases, there is quite a lot of stagnation of food in the stomach. Now, this will lead to a feeling of fullness. You eat a small amount and then you feel full because the food is not really clearing, and you may already have some food which is left over from the previous meal also still sitting in the stomach. This will lead to nausea, and occasionally it can lead to vomiting. And if you have a significantly slow stomach and you're not able to eat properly, that can then start to lead to weight loss as well, which becomes a bit worrying. However, what we also find is that there's a small proportion of patients who have rapid gastric emptying, whose stomach empties too fast. And this is something that is also described as dumping. So the stomach is dumping the food into the small bowel too quickly, and we'll come back to that a little bit later, and we'll talk about the consequences of that. And we tend to find that this more rapid stomach emptying occurs in patients who have POTS. We don't understand why that is the case, but certainly appears to be more common. And there's certainly one paper which has described the presence of rapid gastric emptying in patients with postural tachycardia syndrome. Now, coming to the lower gut, constipation is the most common symptom that we see, and there are two reasons why people develop constipation. The first is the fact that the transit in the gut is slow, so transit in the colon in particular is slow. So here's a study which is called the radio-PEG marker study. So patients are given some capsules which are radio-PEG. And then you take an X-ray 5 days later, and what you expect is that all of these capsules would have passed through the bowel and would have been evacuated in a normal, healthy subject. But what you find here is, because this is an X-ray and because these markers are all visible on an X-ray, you can see that all the markers are still present in the colon, mostly on the left side of the colon, but some in the middle part of the colon as well. So this means that the transit of these markers is very slow in the colon, and we describe this as slow transit constipation. However, you can also have difficulty in evacuation. So you sense the stool in the rectum, it's there, and you get a call to stool, you go and sit down on the toilet, and you try and evacuate, but it becomes very difficult to get rid of the stools. The stools can be very hard. Some people describe them as small, pellet-like, rabbit droppings, or pencil tin-like stools. And the reason for that can be that there is a problem in the pelvic floor, and there can be anatomical problems in the pelvic floor. One, that the pelvic floor can be too flexible and mobile and drops down too much and doesn't generate enough force to expel. But they can be, so this is what you see is in an anatomy of a normal rectum. So it's actually this is the anal canal, and then it curves up slightly and then goes and meets the rest of the colon. And this is where, when the stool is present, you sense it. Now, what you see here is that there is a bulge that is formed in the rectum, or a pocket, you can call it, as formed in the rectum, that is pressing anteriorly over the vagina as well. And what can happen is that as the stool comes down, it drops into this pocket. This pocket is called a rectocele. And even though some of the stool will come out, the stool that is lodged into this rectum will give you a sense of incomplete emptying. The patient say, well, I passed some stool, but then I feel there's something left, but I can't get rid of it. And in those patients, quite not uncommon to find that there is a rectocele with a bit of stool that is lodged in there. And sometimes we also see that the rectum, as you strain to empty it, it can collapse internally. So it's like a concertina effect, that the rectum will sort of fold onto itself, and it's called an internal collapse. It's also described as an intersusception. Intersusception means exactly that. It's folded onto itself, collapsed onto itself. And that can produce a feeling of obstruction. And studies have shown that these anatomical problems are much more common in patients with EDS and hypermobile spectrum disorders. Now, what is the consequence of there being a very sluggish gut? We've been talking about the fact that the esophagus is sluggish, the stomach is sluggish, the bowel is sluggish. What does that lead to? Well, one of the consequences of that, stagnation, you've got food, fluid, stool, all mixed in together in the gut, in the bowel, is that there will be a situation where you get, instead of a river, nice river flowing, you'll get a pond there, or even like a swamp. And that means that you will get a lot of unhealthy bacteria growing in the gut. You have to remember that there are millions of bacteria in the gut. These are healthy bacteria. They're part of an ecosystem. They help us to digest the food. They're mostly friendly bacteria. It's in their interest that we remain healthy the longer we're alive, and they have a host to live in, and they enjoy the fruits of our labor, and whatever we eat, they help is food for them. So they want us to survive as long as possible. So they help us with digestion. They help us to regulate our immune system in the gut and so on. But when these bacteria become unhealthy, they start to ferment your food. They ferment it. They cause unhealthy and metabolic products to form. They actually mess up the immune system of the gut as well, because these unhealthy forms are recognized by the immune system, and the immune system becomes reactive to them. And the consequence is that you start getting symptoms. This fermentation will release a lot of gases. Those gases will cause bloating and distension and a feeling of fullness, and patients start to feel unwell. In some cases, there can be severe cramping abdominal pain, and the stools can pretty much look like the water that you see in the swamp. They look oily, they look like slimy, float, difficult to flush. They can be quite foul smelling, can be associated with a lot of wind, etc. And that's usually an indication that the gut bacteria now, because of this stagnation, have become very unhealthy, and there are quite a lot of unhealthy forms which are leading to some of these problems. And this sort of oily stools are really because fat is becoming malabsorbed in the gut, in the small bowel. And there are lots of consequences. If fat is not absorbed very well, then you don't absorb certain vitamins and minerals, etc. as well, and the health and nutrition can deteriorate. And there's another consequence of constipation. So if you look at the figure on the right, and you just see here that you have normal gut bacteria here, normal bowel here with normal amount of stool in the rectum, and when people have a cold to stool, they will empty it, and you have largely an empty rectum. But in patients with severe constipation, there is a lot of stool in the bowel, particularly in the lower bowel, in the rectum area, and this stool is not passing through as well as it should do. So what can then happen is that sometimes bits of the stool on the edges will break down and come down as liquid stool. So what we describe as overflow diarrhea. So it just gushes down into the lower part of the rectum. You sense it and you have to rush. There's a sense of urgency. You have to get to the toilet immediately and try and evacuate that stool. And it's usually a very liquid stool. So this gives the person a misconception that, oh, I've got diarrhea, and they may even start taking anti-diarrheals, which will make the problem even more difficult and more severe, because the constipation will get more severe, and consequently this overflow diarrhea. So just to try and help you explain this a little bit more, you imagine that there's a big iceberg there on a mountain, and around the mountain, as this ice melts, you get this waterfall coming down. So in the same way, you actually have a lot of solid stool there in the rectum that melts on the edges. The only way for it to get through is to melt on the edges, and it comes down almost like a waterfall, and that can cause quite severe diarrhea. And we tend to see this, that when we give laxatives to try and clear the bowel, which is very, very full, you tend to see initially this overflow diarrhea as the stool breaks and comes down as liquid stool. And this can again give more of a false sense that, oh, this laxative is too strong and it's actually causing me all this diarrhea, and patients tend to stop their laxative, which is not the right thing to do. You just have to persevere and let it all come through. Okay, so then we move on to the discussion about the sensitive gut. And the gut is, an organ which has a lot of nerves there. So these nerves, when they're inflamed or injured, can become more sensitive. So just like if you drop a bit of oil on your hand, the skin on the hand can become more sensitive. The gut can also become more sensitive. But if the stimulus is too strong, you can actually get increase in sensitivity going up at the level of the spinal cord as well, because the nerves from the gut will go through the spinal cord first before they go up to the brain. And you can get this sensitive focus occurring in the spinal cord as well. So when the nerves are sensitive in the gut, it's called peripheral sensitization. When the nerves are sensitive at the level of the spinal cord, it's called central sensitization. And even though once this inflammation is healed, and if you develop central sensitization, then the nerves can remain sensitive. So central sensitization, once it occurs in the spinal cord, can then keep the nerves very sensitive for a long period of time. And then if you have stress, anxiety, etc., that also affects the sensitivity of the nerves, because there are signals that come from the brain down to the level of the spinal cord, which are normally inhibitory. They inhibit pain, but when you're stressed and anxious, these inhibitory signals are less, so therefore more pain goes up. So it's a very integrated system as to how the nerves, both at the level of the gut, at the level of the spinal cord, can get sensitive, and then at times of stress, etc., everything gets worse. And it has been described that patients with hypermobile EDS tend to have a tendency to develop more sensitivity. Their nerves are more sensitive, and therefore, whenever they're injured or inflamed for whatever reason, they develop this sort of central sensitization and peripheral sensitization. And of course, there have been lots of studies show that stress, anxiety is also more common, which is probably a consequence of the number of symptoms that our patients experience, and therefore, that can make the pain worse. And I just want to make you aware of a condition which is often missed, which is called an abdominal wall pain. So we have to remember that all the pain that comes from the tummy is not related to the organs of the gut. There are lots of muscles at the front of the of the tummy wall. For instance, this is the rectus muscle in the middle. This is the muscle that people go to the gym and work out and try and get a six-pack. But what we often forget is that there are these nerves. These white bits over here that you can see, these are all nerves coming through the muscle, as you can see over here. And you can get entrapment of nerves as they go through the muscle, because these nerves, this is the nerve, they go through a canal. It's a fibrous canal, and the nerves come out at right angles. There's an artery next to it as well. And you can get tightening of the nerves in this canal, and that can cause entrapment, and that causes very severe pain. You might have heard of carpal tunnel, where you have the median nerve, as it goes through the wrist, it goes through a little canal there, and it can get caught up, which causes pain in the hand. In the same way, if you get this nerve trapped in this muscle, that can cause very severe pain. And for whatever reason, patients with hypermobile EDS, this type of pain, abdominal wall pain due to nerve entrapment in the muscles, is quite common. A third of my patients that I see in the clinic with tummy pain have this nerve entrapment, and that's usually presents as very sharp, very localized pain, always in the same area. Movement makes it worse. If you lie down in a certain way, it makes it worse. If you bend down to pick something up, the pain gets worse. And this pain can be there 24/7. It can come and go. But when it comes, it can be there 24/7. And it gets worse as the tummy distends after you eat and the muscle stretches. So it's often said that, oh, this is caused by eating. But in fact, it's coming from the tummy wall. It can be treated by deep tissue massage, application of heat, application of non-steroidal gels, and sometimes injection of local anesthetic with steroid, and you get a very good response. Going on to leaky gut, so just to show you what the cells on the surface of the lining of the gut looks like. So this is what normal cells should be like, that there should be no gap between the cells. I talked about these finger-like projections before to increase the surface area for absorption, but these are the individual cells, and there are no gaps between them. So this is what the healthy lining should look like. And here you have a leaky gut where there are gaps that have appeared between the cells. And this tends to happen if the gut is a bit inflamed. And when you have this leaky gut, then all the stuff that is present in the lumen of the gut, these dietary proteins and drugs and various other things, enzymes, they start to get through, which shouldn't be getting through. And this leads to overactivity of the immune system. And the first line of defense, as something gets through this breach, when stuff gets through which shouldn't be getting through, the first line of defense or the bouncer out the gate is the mast cell. Okay, so the mast cell comes out and says, hey guys, stop. Don't try and come through. But if this offending protein or whatever dietary thing is persistent, then the mast cell gets activated. So these, what we call antigens, these foreign proteins, they dock on to specific receptors on the mast cell, and the mast cell then degranulates. It starts pumping out all these chemicals to try and get rid of these proteins and antigens coming through. And one of the key chemical that it spurts out is histamine. And histamine then flushes the system and leads to a lot of effects. Now, once this barrier function is breached, then a lot of problems occur. Food allergies and intolerances starts to occur. There are immune system abnormalities, and this is also considered to the basis of autoimmune conditions like lupus, etc. Are considered to be due to the breach of this barrier function. But just a word on mast cell activation, and I'm not going to dwell on it because I know that Dr. Maitland is going to be speaking to you about it in much more detail. But just to say that this histamine can have wide-ranging effect on the entire body. But in the gut in particular, it tends to produce stomach cramps. And I should add bloating here as well. Patients complain of diarrhea after eating. They have a lot, meteorism is like a lot of wind that they feel is there, and they have to rush to the toilet. And there's often urgency. They can feel flushed. They can have palpitations, etc. So if we find these symptoms occurring after food, then we often think of mast cell activation disorder. But I won't dwell on this, and Dr. Maitland will explain this in a bit more detail. Just moving on to the fact that patients with POTS also experience tummy symptoms as well. And the key reason for that is that, so what I mean to say here is that some patients say we eat and we get dizzy in the same way when we stand up we get dizzy, and to the extent that sometimes they can't even eat upright, they want to lie down or incline themselves at least when they eat. And just to say that the gut has a very rich blood supply. So there are lots of blood vessels which are supplying blood to the tummy cavity. And the important thing to remember is that when we eat, there is an increase in blood flow in the tummy cavity. So there's much more blood coming down into the tummy cavity when we eat to help digest the food. And because patients with POTS, I think, because they're running on low blood pressure already, this drainage of blood from the peripheral limbs and the peripheral circulation into the tummy cavity causes further loss of volume in the circulating blood, and that can lead to the symptoms of POTS of lightheadedness, fatigue, drowsiness is a common. Occasionally we see fainting, but nausea and bloating are common features of these type of symptoms as well. And then I talked about if the stomach empties very rapidly, you can get a condition called dumping syndrome, which occurs within 15 to 30 minutes of eating. And basically the stomach is too fast and it dumps the food down into the small bowel. And if this food has a lot of sugar and carbohydrates, then this sort of sugary content in the small bowel increases. That absorbs fluid from the blood vessels, and therefore the volume circulating in the blood vessels decreases, and people tend to get weak, dizzy, they get palpitations, tummy cramping, etc. So this can be another feature, problem that we see sometimes in POTS patients, and I'll talk about the treatment for that in a minute. So how do we manage all of these problems? So the general approach is that a lot of our patients sadly been told there's nothing wrong, we've done all the tests, nothing shows up. So they're often given the feeling that, oh, this may well be all in the mind, etc. And so just reassuring them that we know that there is a problem, we know that hypermobile EDS is associated with a lot of these tummy problems that you described, And there is an explanation for the multiple symptoms that you're experiencing in the entire gastrointestinal tract sometimes. And this is often quite reassuring to our patients. And then we really need a multidisciplinary approach of what we call MDT approach. We need to have a dietitian in our team. We have to have a pain management consultant in our team. And also access to colleagues who understand POTS, who understand problems with joints, who understand the urinary tract involvement as well, so that you can refer them when you screen them for all of these problems and you see that they have a lot of these problems. You can refer them to the people who will also understand what the problem is. And of course, having multiple symptoms can lead to stress and anxiety and sometimes depression, and having a psychologist on your team is also helpful. The first step is really to exclude any other organic condition that may be present in our patients, because it has been noted that patients with EDS sometimes can have inflammatory bowel disease like ulcerative colitis and Crohn's disease, or celiac disease, or an autoimmune connective tissue disorder like lupus or rheumatoid arthritis and so on. So one needs to do a basic screen to make sure we're not missing anything. And if this screen comes back as negative, then there are special tests to understand how the gut functions. So the problem here is not anatomy, it's not structure of the gut. The problem is the function of the gut. And if you don't do the test to understand function of the gut, then you're going to miss problems. So you do tests for esophageal motility called esophageal manometry. You can do 24-hour pH, which tells us whether there's excessive acid coming up. You have a stomach emptying or a gastric emptying study. Hydrogen methane breath tests tell us about whether you've got excessive bacterial overgrowth. A clonic transit study will tell us if the bowel is very slow. And then, rectal physiology studies are studies which tell us whether the back passage is too sensitive or it is actually moving very slowly, whether there is an anatomical problem like a rectal seal or an intussusception. So all of these things can be diagnosed with the right tests that are available to us. Food intolerance is very common. A lot of our patients complain of intolerance to foods, and mostly this is because they are intolerant to what we call FODMAPs, foods that are highly fermentable. And this is because the gut is sluggish. We talked about the fact that there's unhealthy bacteria in the gut. And if you eat foods that are very easily fermented, then you're more likely to get bloating, cramping, distension. So this is what there are some resources that I've listed over there that one can look at. And there's a study that has been published very recently suggesting that FODMAP diets help patients with EDS much more so than they help with patients with irritable bowel syndrome, because this diet was originally developed to treat patients with IBS, but patients with EDS seem to benefit quite a lot from just reducing the fermentable carbohydrate load. Low histamine diets are also discussed in terms of patients with mast cell activation disorder or histamine sensitivity, and some patients do respond to it, but I would strongly advise both the FODMAP and the low histamine diet should never be done without proper discussion with your healthcare physician, and should be done in the guidance of a dietitian, because these diets are not forever. You just do them for a short while and then you reintroduce foods to find out what your trigger foods are. They're not meant to be carried on forever. So do consult with a healthcare professional if you decide to go on to try any of these treatments. And then, of course, with patients with histamine problems, antihistamine mast cell stabilizers, but I'm not going to dwell on that, as Dr. Maitland will cover that. In patients with who develop POTS-like symptoms after meals, we normally tell them, especially if their stomach emptying is very fast, that they should eat small meals more frequently. Larger meals are more likely to produce symptoms. Opt for low glycemic index foods, which means foods that are low in their sugar content and complex carbohydrate content. Increase the fat and protein intake, because fat and protein slow stomach emptying down a little bit. So if the stomach is emptying very rapidly, you're getting dumping syndrome. That can increasing the fat and protein content can reduce that dumping. I also say to people who are dumping, or getting more POTS-like symptoms after meals, to avoid liquids for half an hour before, during, and after meals, so that the liquids don't wash all your carbs down into your small bowel, and then that produces the symptoms that patients experience. Lie down for 30 minutes after a meal, which reduces some of these symptoms of palpitations, flushing, or dizziness. Increase your salt and water intake. And pharmacological management of POTS, which I will not talk about because other colleagues will be talking about that. Pharmacological treatment of POTS sometimes will help the tummy symptoms of POTS as well, and it's worth keeping that in mind. Then in a small, very small group of patients, enteral or parenteral, which enteral means feeding directly into the gut, either through a PEG tube or a PEG-J tube, or intravenous nutrition is required. But one has to be very cautious about this because there's a high failure rate with these methods of nutrition. Infections are common. Pain is a common feature, especially in those having direct feeding into the tummy. And therefore, one has to decide on who's going to go on these very, very carefully. And consider all the other factors that could be contributing to the problem with nutrition, like POTS and mast cell activation disorder, abdominal wall pain, bacterial overgrowth. Quite often by correcting these, we can prevent people going down this enteral and parenteral nutrition. And of course, psychological issues need to be discussed. Anxiety and depression can sometimes go to the extent that that starts to affect nutrition. And very, very occasionally we come across eating disorders as well. And sometimes that is related to the fact that people learn to control their eating to try and reduce their symptoms, which then gets out of control. So all of these issues need to be considered. Avoid opioid painkillers because opioids like morphine, pethidine, codeine, they all slow your gut down. The gut is already slow. If you take these type of painkillers, that's going to make the gut even more slow and will cause a lot of dysfunction of the gut. The treatment for pain where the nerves are very sensitive are what we call pain modulators, gabapentin, pregabalin, amitriptyline. SNRIs are also antidepressants like duloxetine, etc. So these are all medicines that reduce the sensitivity of the nerves in the gut and will help to reduce the pain. So these are the type of medicines, even though they're not devoid of side effects, but nevertheless much better than opioids for the management of pain. And of course, psychological approaches when there is a lot of stress, anxiety, and depression, cognitive behavioral therapy, hypnotherapy, deep breathing, and sometimes SSRIs, serotonin reuptake inhibitors like fluoxetine, etc., are necessary to try and help our patients. For management of constipation, dietary measures such as just keeping the stool soft with foods that are high in fiber content like prunes. Movicol is a pegylated solution. It basically helps to soften the stool by absorbing water in the stool. So Movicol is usually a very good place to start with the management of constipation. But often we have to add stimulant laxatives like Senecot or Dulcolax that helps the gut to move a bit stronger. And combination of these with a softener with a stimulant laxative is often helpful. And then the next step up is Resolor, which is also called prucalopride, which is not a laxative, but helps the nerves and the muscles to move much in a stronger way. It's a class of medicines called prokinetics because they improve the kinetics or movements of the gut, and some patients require that. And in those who are having a lot of evacuatory difficulty, sometimes taking a glycerin suppository or a bisacodyl suppository, sometimes we have to go to enemas or rectal irrigation kits to try and help evacuation. And occasionally patients need surgery if the rectocele or the prolapse is quite large. Probiotics can be helpful in patients where bacterial overgrowth is an issue. So once you've treated the bacterial overgrowth with sometimes antibiotics like rifaximin, but low FODMAP diet is also helpful in reducing the effect of bacteria in the small intestine. But sometimes in addition to all of that, we tend to use probiotics as well. So just to summarize, it's a multi-system disorder and you require a multidisciplinary approach, which is often not available, and one needs these commission services really to try and help manage our patients with hypomobile EDS. And just to really thank all the colleagues who've been helpful over the years in the work that we've done, and of course Ahlers-Dnlus Society and EDS UK have always been very helpful in supporting our work. Thank you very much.
Thank you, Professor Aziz, Kasim. And I would like to ask you if you can look at the questions in the chat. You can open the chat when you're looking down, and there are a few questions for you.
Okay.
Do you want me to read it out for you? To get out of the screen share.
And I'm just trying to figure out how to do that.
You just
screen sharing has stopped. Okay, excellent. Thank you. Thank you very much. Now, questions. Right.
In the chat.
In the chat. Okay. Do you recommend pelvic floor physical therapy? The answer is yes. There was, in my slide, I was running out of time, so I actually skipped that a little bit. Biofeedback was mentioned when we talked about the pelvic floor problems, okay, and biofeedback is pelvic floor therapy. And there are some very good specialist nurses and physiotherapists that provide biofeedback, which is really aimed at strengthening the pelvic floor muscles and reducing the strain that you produce. There are breathing exercises, the way you sit, etc. So yes, pelvic floor therapy can be very, very helpful. I suffer from disruptosis of the bowel, which affects my life tremendously. There seems to be no experience with this condition here in Israel. Are you familiar with any expert around the world I can consult with? Disruptosis, I normally have a slide. For some reason I didn't have one today. Disruptosis is when the organs of the gut are hanging very low, and there's a change in the position of the organs between lying and standing. So when you stand up, the organs, the stomach, the small and the large bowel, they fall down towards the pelvis with the effect of gravity. And that's because the ligaments are very lax and loose, and they don't hold the organs where they should be, so they fall down. Now, this sadly is a rare condition, very uncommon. We see this from time to time, and I've currently got 2 patients that I'm looking after with this condition, and one of them is very distressed because of the pulling that produces on the gut. Now, what we're also discovering is that along with disruptosis, sometimes the blood flow around the organs also decreases when the organs fall, and the symptoms are not produced by the organs falling, but it's through the reduction in blood flow. There is very, very little experience of this around the world, and I'm not aware of an expert as such in disruptosis. We're gaining some experience with it in our department over here, and we are working with a group of other colleagues who have some experience with this condition. But I'm generally told that if there is one organ which is falling low, you can hitch it up with surgery. But if there are multiple organs, then that can be very, very difficult. So this is an area where we still need to learn a lot, and a lot of research is required. But one has to look at each individual case and decide what the what the best possible treatment option is. What treatment is recommended for EDS-related non-inflammatory reflux? So there's always treatment has to start with more holistic approaches. Okay, so we know that reflux gets worse with certain types of foods, and the sort of foods are very high fat, high starch, sugary type of foods. So just changing your diet a little bit and reducing some of these foods that are unhealthy, processed carbs, refined sugars, just reducing those can help. Eating small amounts frequently can help. Reducing weight can help. Stopping smoking and drinking too much alcohol will help. So these are just simple basic things to do, lifestyle measures, which can be very helpful. But if these are not helping, then there are medicines that will help to control and reduce the acid in the stomach. They're described as proton pump inhibitors, omeprazole, lansoprazole, etc. are very helpful to help control acid reflux. And then there are other slightly milder drugs like histamine receptor antagonists like ranitidine. Ranitidine has got a problem at the moment because it's got an ingredient which the FDA has banned. But there are other medicines like cimetidine, famotidine, etc. that also help to reduce stomach acid, but they're not as strong as the proton pump inhibitor. So there is certainly pharmacological treatment available for that as well. And there's a question, is there a connection between reflux and breathing problems? Yes, there can be. It's uncommon, but in patients who have asthma, it has been noted that if they have a lot of acid reflux can make their asthma worse. That's because the nerves that supply the esophagus and the nerves that supply the lung are the same. It's the vagus nerve that supplies both. And sensitivity in one organ, like in the esophagus, in close proximity to another organ, like the lungs, so there can be cross-sensitivity between the two organs. But very rarely, reflux can be so severe that it comes all the way up into the throat, and at night when you're lying down, it can trickle slowly into your larynx and into your lungs, and which causes a little bit of aspiration, which can also make the breathing worse. But that's quite uncommon, and there are methods to diagnose it and treat it. Okay. What else? There's a connection between EDS and pelvic floor dyssynergia. Yes, there is. There is a connection between EDS and pelvic floor dyssynergia. Dyssynergia means that there's not just enough strength that the pelvic floor can muster up to try and clear the bowel. So yes, there is a connection between that. And we have written about it, and we are writing more papers in that. There's another paper that we currently actually just finalizing. It should be going out to a journal very soon, which clearly demonstrate that pelvic floor dyssynergia is more common. Is there a connection between EDS and chronic loose stools? Yes. And I explained to you there are three reasons that people with EDS get loose stools. One is bacterial overgrowth, unhealthy bacteria in the gut, causes fermentation of food, causes malabsorption of fat, and this is the type of diarrhea that is, as I described, fatty, oily, messy, foul-smelling type of diarrhea, which is usually due to excessive bacterial overgrowth in the gut. Treated by getting the bowels moving, treat the constipation, and sometimes we have to use gut-specific antibiotics like rifaximin, neomycin, etc. to get rid of the bacterial overgrowth. The second type of diarrhea is overflow diarrhea. Very severe constipation, bits breaking on the edges, coming down as liquid stool. I explained that in my lecture. The third type of diarrhea is what we see, the food allergy, mast cell type of diarrhea that we see. That is related to meals. You eat something, cramping. So that is the third type of diarrhea. Then treatment of mast cell problems can help to improve that. Okay. So I realized that diarrhea could also be caused due to a problem in mast cells. Yes, that's true. That's why we found out that when my son's antihistamine helps the seizures of diarrhea. I suppose you're saying that your the antihistamines help with both seizures and diarrhea, which is fine. We see that antihistamines, we tend to use antihistamines for treatment of diarrhea in mast cell patients. Is there a connection to obesity? There's no proven connection to obesity as far as I know. Can you have slow emptying and dumping alternatives? This is a very, very good, very interesting question. Yes, the answer to that is yes. How does that happen? So the stomach is not a fixed, rigid organ. When the food comes in, it becomes, as I said, a mixture. It mixes the food. Lots of movements that are taking place, and then the stomach then slowly empties. But if the stomach is rigid, it's not moving very well. It is slow. So solid food will be slow in emptying, but liquids will be quite fast because of gravity, because normally it should, as soon as the liquid or solid comes in, it starts squeezing and moving. So it controls the movement, but now it's not controlling anything, and the fluid will just trickle straight down. The fluid will just trickle straight down. And as it goes down, it takes with it other stuff, carbohydrates, sugars, and so on, and you can get dumping, even though overall the stomach is quite slow. I don't know how we're doing with time. Is there still time, or?
You have 2 more minutes. Actually, there is one question here that's so up. I'm going to ask it for the one who asked it. Someone is asking about the connection between bilirubin high bilirubin, high eosinophil levels, and is it related to Ehlers-Danlos or bowel disorders of Ehlers-Danlos syndrome?
Increased incidence of eosinophilic problems. We see that there is not a lot of literature on it, but in my clinical experience, yes. I have seen people with eosinophilic esophagitis, for instance, with EDS, and there is one paper which describes an increased incidence of eosinophilic esophagitis and other eosinophilic problems in the gastrointestinal tract, particularly in children and adolescents. There is some description, which is just a very small paper, and I've certainly seen it as well. What was the other part of the question? It was eosinophils and
bilirubin, high bilirubin levels.
Bilirubin, no. I've not come across anything related to bilirubin liver function problems in EDS.
And the last question here is, can gastrointestinal issue cause back and pelvic pain?
Yes, it can. Anything which causes severe constipation, because you've got a huge load of stool lying in the pelvis, which can press on the pelvic nerves, and the pelvic nerves pressure can sometimes lead to a heaviness in the pelvis, and sometimes that relates to pain and discomfort radiating to the back. And so the answer is potentially yes.
Thank you very much for your time and your very valuable lecture.
My pleasure. Thank you. Thank you very much for having me. Thank you.
Yeah.